8-month-old boy. He has AML with CNS1. He presented with fever, abdominal pain, and poor oral intake for the 10 days prior to admission, and there is abdominal mass palpable. So, physical examination on admission noted multiple shorty bilateral cervical lymph node, and also lymph node enlargement, lymph node palpable over the axillary and inguinal, but all less than 2 centimeter. He has hepatosplenomegaly but unable to measure as the patient was full. There is an irregular mass felt over the upper abdomen which is firm with irregular margin. Other systemic examination was not remarkable. CT abdomen was done, revealed a ill-defined hypodense lesion over the upper pole of left kidney with a large matted para-aortic and para-cava lymph node. An ultrasound guided biopsy was done 2 days after. It shows that it is a small round cell sarcoma, and they did the ICH, show BCL2 positive, but the stain for this neuroblastoma, and which is not conclusive, but the markers they didn't stain for the marker for AML. Blood investigation show bicytopenia, whereby the HP and the platelet were low. Full blood picture revealed pancytopenia, but there is no blast. Bone marrow aspiration and T5 was done and show that there is 85% of myeloblasts, and IPT confirmed AML. This is the molecular study. Shows that the patient has KMT2A mutation, and also cytogenetic, as shown here. It started on chemotherapy BFM AML protocol. Induction 1 was AIE protocol on the 5th of July, followed by induction 2 HAM on the 9th of August, 1 month apart, and then consolidation. Okay, we have reassessment BMA done after the chemotherapy. Post-induction 1 chemotherapy, the BMAT was done on the 9th of August, and after that we have a post-induction 2 BMA, which was done on the 14th of September. We reassess the patient with CTTAP as well, and it shows that there is significant smaller lymph node over the mediastinal and also intra-abdominal. So we would like to discuss the BMA result to ascertain the disease remission. Thank you.
Okay, Assalamualaikum warahmatullahi wabarakatuh, and good afternoon. Everyone can hear me, right? I'm Dr. Nurima. Will present the bone marrow findings and also the immunophenotyping for the Muhammad Yusof. Sini share screen. Screen lah kan? Okay. Okay, so this is the FBP that we received during the diagnostic marrow. So from the full blood picture, the FBC shows pancytopenia, whereby the HB is moderate anemia with neutrophil of 0.5. Platelet is 93. So pancytopenia with there is presence of occasional blast cell seen that we can see in the peripheral blood. However, the blast that we suspected blast is seen at the thick area lah. So somehow, sometimes it could be monocytic, and a bit when we can see whereby we can see the blast is large in size with bluish cytoplasm and prominent nucleoli. So we will look further from the bone marrow aspirate for this case. Okay, so the bone marrow, for this case, they did the bilateral bone marrow aspirate. So actually both sides shows, the fragment shows hypercellular for age, and the cell trail also very hypercellular for age. So as we can see in the low power, the cell trail composed of apa tu, monotonous cells. The cells looks like apa tu, same morphology. There's not much of variation in the cell trail. So we will look further under higher power. So the cell trail consists mainly predominantly blast cells. So it is about more than 85%. There's blast cells. These blasts are large in size with abundant basophilic cytoplasm, and there is some cytoplasmic projection that we can see in the cells. Okay. And the blast shows a very immature nuclei with irregular nuclear outline and prominent nucleoli. However, there is no auroch was seen. Okay. And the normal hematopoiesis, which is the erythropoiesis, the myelopoiesis, and megakaryopoiesis, are markedly suppressed. So from this, it's suggestive of acute leukemia. Okay, so these are the trephine biopsy that we obtain from the patient. So this the above one is the from the right trephine biopsy, and the below one is the left from the left trephine biopsy. So from the right side, it shows actually we have two cores of the trephine biopsy. This is one core, and these are the other one. Okay. So, but from both from the both core, it shows a fragmented bony trabeculae with presence of 10 accessible marrow spaces that we can actually assess what is the cells. But from the left side, it also fragmented bony trabeculae. However, there is only about 6 accessible marrow spaces that we can see. Here there is a crush artifact, and there is some area loss of marrow tissue also seen. When we look further under higher power, from the right trephine biopsy, actually both sides show similar findings. So it shows hypercellular hypercellular marrow tissue. There is no fat spaces was seen, and from here we can see the marrow tissue is diffusely infiltrated by blast cells. These are the blast cells that the cells are large in size with immature nuclei. Okay, and there is a prominent nucleoli seen. Okay, the normal hematopoiesis are markedly suppressed. Here is the left trephine biopsy. It shows similar findings. Okay, these are all the blast cells. Large in size with eosinophilic cytoplasm and prominent nucleoli. Okay, from this it's suggestive of acute myeloid leukemia. Okay. Then we proceed with the bone marrow sample for immunophenotyping. We receive EDTA peripheral blood for immunophenotyping. Okay, from the analysis, at first we did acute leukemia orientation tube. So from here, we concentrate on the population in the red color. So the red color populations at the CD45 dim, and it's about moderate to high side scatter. However, there's no CD34 expression, and the population of interest expressing cytoplasmic myeloperoxidase (CMPO) is positive, so it towards myeloid lineage. And however, the B lineage, B cells markers and T cells marker are negative. Okay, so then we proceed with the acute myeloid leukemia panel. Okay, from the acute myeloid leukemia panel, this is from the tube 1. So here we concentrate on the population in the red and the blue color. So the blue color population is actually I just want to show there's some of the population expressing CD117, which is the blue color population. But then is actually the blast population is the blue plus the red color population. So the blast expressing HLA-DR is positive, and CD33 is positive, and part of the blast express CD117. The blast doesn't express CD13, CD16, and CD10. So from here, it is actually towards myeloblast, confirm myeloblast. Okay, from the second tube of AML, so from this tube, actually we want to further assess the marker that expressed on the myeloblast. So from this tube, we can see the blast expressing CD64. However, negative for CD35, CD14, and CD300E. So CD64 is actually a marker, one of the marker that can be expressed in the monocytic or monoblastic lineage. So as it mature, if the cells is mature, it will express CD300 and CD14. So however, this population doesn't express CD14 and CD300E. So it's actually this population actually immature one. So from the immunophenotyping, the blast actually express CD45 intermediate, moderate to high side scatter with expressions MPO, however negative for CD34, D and T marker, and some of the blast express CD117, whereby there is 21.7% blast express CD117, HLA-DR, CD13, and CD64 is positive. So from this, we conclude the bone marrow IPT consistent with acute myeloid leukemia. Okay. So, this one is actually leukemia translocation study from the bone marrow sample from this patient. So from the from the screening panel of the sample, so it shows there is presence of band at the M2 region. So from here, we will proceed with the split out panel to know further what is the mutation that present in the patient, in the sample. So from the split out panel, this shows in the split out panel for M2, so it has 5 tube, 5 channel lagi. So from this patient, from this split out panel, it shows there is presence of band at the M2E. So from here, we conclude that this patient has translocation T911, KMT2A, MLLT3. So the diagnosis of this patient, AML with translocation 911, KMT2A, MLLT3. Okay. So further acute myeloid leukemia study that we sent to IMR shows there is no mutation detected in the FLT3 gene. Okay, subsequently, patient was started for treatment, and on 8th of August was the first assessment marrow was done. So from the FBP with the reassessment marrow, it shows the hemoglobin is 10.8 with neutrophil 0.8. Platelet is already come back, is already normalized to 194. So however, from the full blood picture, there is no circulating blast seen. Okay, this is the marrow done on the first assessment marrow. It shows the fragment shows quite normal cellular. However, some area shows hypocellular. So we conclude it's normal cellular fragments for age and with a cellular cell trail. Okay, so the cell trail is actually very different from the diagnosis. Okay, so here we can see predominantly there is erythroid precursors. Okay, they are when we count the cell trail, predominantly there is erythroid precursors, and there is presence of myeloid precursor and the neutrophils. So and from here there's no from this shows there's only maybe one blast seen here. Okay, we will look further at the higher power. Okay, so as I said, the erythropoiesis is active. So when there is a mild erythropoiesis whereby we can see there is an intercytoplasmic bridging. Okay, and the myelopoiesis is adequate with all stages of maturation are present. So here we can see there is a myelocyte, metamyelocyte, and these are also myelocyte. Okay, and there is a neutrophil also seen. Okay, so the megakaryopoiesis is adequate with lymphopoiesis unremarkable. There is only we get when we count the when we do the blast counting, there is a presence of 3% of blast in this first assessment marrow. Whereby here is the blast and here. Okay. So during first assessment marrow, we also did receive sample for bone marrow immunophenotyping. Okay, from at this time, actually we did 2 tube during this assessment. We did the AML tube 1 and also the MRD ball tube 1 to assess to assess the hematogens if present. Okay, from the AML tube, we concentrate on the red population in the red. Okay, so there is a presence of 2% myeloblasts in this sample. So whereby the blast express CD45 dim and moderate side scatter. The CD34 is heterogeneous with expression of CD117. And HLA-DR also is heterogeneous. CD13 is positive and CD33 is heterogeneous. Okay. So from here we can say there is presence of 2% myeloblast. However, we cannot differentiate whether this is normal myeloblast in the marrow or abnormal myeloblast, because the normal myeloblast also express similar features. Okay, from the another tube, MRD ball tube 1. So from here, we want to assess the hematogens. Here, in the red population, is actually there is a CD34 positive hematogens, and the blue population is actually CD34 negative hematogens. So I think from the first presentation just now, from the first case just now, we already know what is hematogens. So here, why we said this is hematogens. So because this population, both population, the CD34 positive and CD34 negative, doesn't express abnormal aberrant marker there is no express aberrant marker. So it express the normal maturation pattern of the B cells precursor in the on the cells. Okay, whereby the CD34 positive it express CD10 and CD20 is heterogeneous, and the CD38 is positive, and CD58 is negative, and CD66 is also negative. So this is actually the normal pattern of normal pattern of CD34 positive and CD34 negative hematogens. Okay. So from these IPT findings, it shows no excess in blood cells. So it's actually tally with the morphology findings. Okay. So subsequently, 1 month later, they did second reassessment marrow. So from the full blood picture, the FBC shows good hemoglobin level with neutrophils of 1 and platelet also still okay, but however if we compare with the normal range, it's actually at the below than the normal range. So here, from the FBP, it shows leukopenia with neutropenia and lymphopenia. However, no blast was seen in the peripheral blood. Okay, this is the second. This is bone marrow they did during second assessment. Okay, it shows the fragments are hypocellular for age with hypocellular cell trail. Okay. So, however, in the cell trail, we can see there is this kind of cells. It's a bit moderate to large in size. So it's actually excess in blast that's present in the cell trail of during this second assessment marrow. Okay. So, however, there's still presence of normal marrow precursor, whereby there is still normal erythropoiesis, and they are still the myelopoiesis is still adequate. Okay, and there is also megakaryocyte also are adequate. Okay, on the higher power, we can see there is a presence of 7% blast cells. So, however, from this morphology, we cannot differentiate whether this cells is myeloblast or or hematogens. Okay. Okay, as from the morphology, we can see there is a presence of excess of blast up to 7%. These are the blasts. The blasts are moderate in size with open chromatin nuclei, and there is a prominent nucleoli was seen. However, the normal hematopoiesis is still present with adequate erythropoiesis, myelopoiesis, and megakaryopoiesis. Okay. Okay, from this sample also we receive ADTA bone marrow peripheral bone marrow sample for immunophenotyping. Okay, so here you can see there is you concentrate on the purple color population, and okay, and the blue and red color population I will talk in the next slide. So from the purple color population, it express CD117, whereby this is actually we recognize this as a blast, is a myeloblast, whereby it express CD117, and HLA-DR also heterogeneous, and the CD13 is positive and CD33 is positive. This population also expressing CD64. However, it doesn't have CD300E and CD14. So we conclude this is actually myeloblast or monoblast. Okay. So
Rima,
yeah.
hi. Sorry, can I just check with you? The IPT that was done for this second marrow and that was done for the diagnostic and the first check marrow, does it has the same CD count, the CD
expression?
Okay,
from the actually from the first assessment, we did only one tube. as you can see here, yeah, there is only this one tube of AML. So it doesn't we didn't do we didn't do for tube 2, whereby we cannot accept we can't tell whether this myeloblast express CD64 or CD300E or CD14. So but however from this tube we can confirm this population is myeloblast. However, this myeloblast we cannot differentiate whether this same as the diagnostic population and whether this myeloblast is normal or abnormal, because the regenerating myeloblast also can have similar phenotype. However, we during the second assessment, whereby we did full we did both AML tube 1 and tube 2. From this analysis, we can see this myeloblast population expressing CD64 and doesn't have 300E and CD14. So we can say this is actually the myeloblast lah. But yeah, quite similar. But then in term of count, it doesn't access more than 5%. So we still say it's actually probably is in remission lah. Because the blast because the blast is not more than 5%.
Correct. Yes. So less than 5%, we will say it is in remission. But what concern is the clone, right? Because we will read about the clonal expansion. So if the clone is different from diagnostic or from the first marrow, then it's a bit worrisome. Yeah. So I'm just wondering whether you all will be doing the markers for the subsequent?
Yes, if we receive the sample for AML reassessment, so we will do both markers for AML tube 1 and tube 2.
Actually, Kogi, you know that we have very limited markers for AML because we need at least 12 colors flow cytometry to assess whether this is the disease myeloblast or not. But I think from what Nurima presenting, you can see that from the CD117 and HLA-DR, so there is heterogeneous expression because the one that at diagnosis, the blast was mainly at the CD117 positive and DR positive. So what we can actually see is basically if there's myeloblast or not, but other than that, whether it's disease or not, we have a very limited marker in our panel. So we can only say the percentage of it lah, unless we can see that it's very different markers. For example, the blast does not express 33 or does not express 13. So then we can comment on that. But in this case, it looks like normal maturation to us lah, which with very limited knowledge that we have, because we need to be trained for that MRD. For the time being, we can only say it's less than 5% or 4%. Yeah.
Yes, correct. So we will not do the MRD assessment, but this IPT is just to see the myeloblast or hematogones or things like that. Yeah.
Or less than 5%. And whether there is combination of hematogones in the blast region. That's what we can say at the moment lah. Until we get the 12 colors flow cytometer and also the techniques to do MRD AML.
Yeah, so hopefully soon lah, yeah?
Yeah, hopefully. Okay, thank you.
Okay, so I proceed with the subsequent tube that we did for this patient. So we did the MRD ball tube 1 to assess the hematogones. So from here, we can see that there is a CD34 positive hematogones, which is in the red. It's about 4.2%. And the CD34 negative hematogones is 4.1%. So yeah, if we sum up the CD34 positive and the myeloblast is about maybe 7 point something. So it's actually whatever we got in the morphology just now, whereby we can get 7% blast. So it actually consists of both myeloblast and CD34 positive hematogons. Okay.
So that's another extra information that we can get from our hematogons. So that's why the total of the blast was more than 5%, but it's actually maybe inclusive of this 4.2% hematogons.
Yeah. Betul. So from here, the bone marrow IPT findings shows no excess in myeloblast. So there is presence of 3.4% myeloblast in this bone marrow sample. Okay, so I think that's all from me from this patient.
Thank you. So unfortunate for this patient, he got admitted with a ESBL sepsis, and now he got splenic abscess. So that will interrupt his chemo quite significantly lah. So what we will do, most likely I will have to do another marrow before I start him on his fourth course of chemo. I'm not sure when that will be.
So the chemo was truncated for this patient, is it, Gogi?
Correct. So he received 3 courses of chemo.
Okay, all right.
And we had to stop subsequently.
If you can let us know in the BMD, so this patient is status, then we will more alerted lah for this.
Yes, and also since we're going to continue with the cytogenetic, probably I can cytogenetic as well for sample clonal changes, right?
Okay.
Can I ask a question before we move on to cytogenetics? To our hematopathologist, you mentioned that there's there's 2 tubes for the AML immunophenotyping panels, right? But at diagnosis, you only did on 1 tube. Just wonder whether you will make a difference if you have done 2 tubes to better characterize the myeloblasts at diagnosis. Would that help to differentiate the cells subsequently?
Dr. Tay, actually at diagnosis, we did 2 tubes of AML. As for this case, we do at the screening, we do a lot tube. Then subsequently, we do AML tube 1 and AML tube 2. It's actually same as what we did during the second assessment marrow.
I see. So you have done what you can do lah, in other words.
Yes.
Okay. All right. Thanks.
Okay, for patient 2, Muhammad Yusuf, we received the sample on the 6th of July with diagnosis of AML. So of the 30 metaphase examined, 13 cells show normal male karyotype 46XY. The remaining 17 show abnormal karyotype. So there's 2 clone was seen. The main clone is made up of the 46XY translocation 911, and this derivative 13 resulted from translocation 113. So for the subclone, we have the same abnormality, translocation 911, derivative 13, and this one got additional trisomy 6. For according to the ELN recommendation, this one the patient have the intermediate risk lah. And then this is the normal karyotype for this patient. So that's all from cytogenetic.
Before we move on, can I ask another question? Dr. Kogi mentioned about sending the sample, the repeat sample for immunophenotyping and then subsequently for cytogenetics as well. We know cytogenetics not very sensitive, but we did identify the molecular mutation for this patient, right? The fusion of 911. Just wonder whether running the molecular PCR again on the reassessment marrow will help at least to differentiate whether there is presence of the same mutated clone at diagnosis.
If the clone is still there, then we should able to detect the same the fusion gene lah.
I
Fish also can.
yeah, I mean by molecular mutation. You'll be by our hematopathology lab, kan?
Yeah, because at the moment we don't do for reassessment. So we're just exploring whether will you be considered for this case.
For the molecular is under hemato team shows
what is the mutation again?
911 translocation.
911 we can detect, but at the moment, I think I discussed in the separate session why we a bit tough for us to do that at the moment. I mean, at the moment we concentrate on new cases only. As it is, we still have a lot of cases backlog that we need to do. If we can get, maybe I'll discuss with Kogi later on, Kogi.
Yeah, sure.
I'll discuss with you.
Yeah, I'm aware of the problems faced by your team.
Yeah. It would be helpful, actually. It would be helpful. It's just that it's a bit difficult for me to commit.
Okay, thank you, Dr. Sharon. You'll move on to the last case.
Dr. Kogi, just now you mentioned that you want to ask about something regarding Adriana
The
Faihal.
first case. Yes. Is it possible to go back? Sorry, my mic was not working. Is Dr. Aida around?
Yes, doctor.
Yeah, so actually I wanted to ask about the first case. How confident is your team to conclude that the day 15 bone marrow is actually hematogons? Because what happens is because day 15 bone marrow MRD is very important for us to stratify our patients. So with that level, high level, this patient actually fulfill the criteria to be stratified to a high risk. Now, unfortunately, this patient took the chemo pretty bad. She came with many episodes of sepsis with micrococcus, and then she also had status epilepticus, where we had to treat her as herpes encephalitis, and then she had abscess, so she had IND done. She got a big wound over there, so her chemo as well truncated. So I want to know if your team is very confident that this is hematogons, then I will not, up her chemo to a high risk.
I see. Okay. If this is agreed by other hematopathologists, then I think this is a hematogon because it does not shows any the same like the one in the beginning, the blast where it is CD34 pause. It's totally located at a different place at the CD45 next. It's not there. It's CD45 bright. We just want to make sure that this is a hematogon. Just that the only thing that we haven't seen before in this hematogon is that the maturation, it was just arrested there. That's all. But there is no light. It was not at all the same like at the diagnosis. So we just concerned on that part. Also, there's no maturation. But then it already shown in the in the day 36 one, that all that the bulk of the hematogon has shifted to the maturation. And we just to be safe, we took the one at the day 15 population, the hematogon population, we took and we assessed further what happened to that, and it doesn't show anything like looks like a blast. So if that's agreed by other hematopathologists as well, I think it looks to me hematogons. And it's actually proven by the day 36. Actually, all of them has gone into maturation. So doesn't look like the blast at the diagnosis. But if you ask me if this the small things that small, it was only 41 over 1 million of cells, and it's very little to say. It's non-specific. It's too little. Yeah, is that agreeable with other Dr. Azlina, Dr. Nurimat?
I think Dr. Sharum is trying to answer.
I'm sorry.
I can't find the. Can you hear me?
Yes, can.
Yes.
I think everybody got the answer already. The thing is, we agree that is the hematogons is just like Dr. Aida say. And the thing is, if it's hematogon, which we haven't mentioned before, if it's blast, the CD45 is bright, and actually once the hematogons mature, it will acquire. If the anything, it will acquire CD45. This one is CD45 is bright. So blast normally is CD45 negative or dim. So it's really against the blast residual blast and other proof that Dr. Aida has mentioned, no naive, and then the different expression as before. So I think is, and the other thing is we tested for the in our MRD panel, we added the CD81, CD123, CD73. It was all within normal, expected. Actually, it's not positive. The expression is as usual, not as the blast population. So we quite confident that is hematogons. It's just that because if it's blast, I just wonder whether with the normal chemo, the patient will go into the blast disappear at day 36. In your opinion, what is your opinion, Dr. Gogi, in that sense, like the response to chemo for this patient?
Yeah, so we have a few patients who are just day 15 marrow has more than 10% blast. That is the only criteria for high risk. So those are true blasts. So we do have some patients that we have to stratify to high risk, but they will clear their blast or MRD negative for on the day 36 assessment.
Without further chemo, I mean.
No. So the patient is undergoing the induction chemo?
Yeah. I mean, you haven't escalated the
No.
protocol yet, but
Yes.
the blast disappear, you mean?
Correct.
Okay, that's your concern.
So I think in this case, if we are confident that this is hematogons, and we do know that hematogons can appear during chemo, then I will just keep a very close eye and I will not escalate her chemo to high risk.
Yeah, we are quite sure at the moment. Yeah.
Okay, thank you. So we move on to the third case, yeah? Thank you.
Siva, we can't hear you.
Sorry, I forgot to unmute. Okay, I will present again. Our third case is Rex Fong. He is a 13 years old boy, previously no medical illness, presented with spontaneous bruising for 2 weeks and fever for 3 days. He had a cleft lip previously, which was repaired, but there is no other dysmorphism. There is a multiple bruises and PTK over the right cheek, abdomen, bilateral upper limb and lower limb. PTK in the oral mucosa, no lymph node enlargement, nor hepatosplenomegaly, and other systemic examination were unremarkable. Investigation showed that he has pancytopenia, and the coagulation profile review APTT 39 slightly prolonged, PT prolonged, and INR 1.4, fibrinogen 220. Full blood picture notice that there is abnormal promyelocyte 57%. And okay, diagnostic bone marrow aspiration and T5 biopsy was done consistent with APML. And molecular study also revealed there is PML RARA gene detected. We are still waiting for the cytogenetics. So this patient, the diagnosis is clear cut, but we would like to discuss it for educational purpose. Thank you.
Okay, Assalamualaikum and a very good evening, everyone. So I'll be presenting the last case for today, which is Rex Fong. Okay. Okay, can you see my slide?
Yeah.
Okay.
Yes.
All right. So this is the full blood picture on the bone marrow procedure. So you can see that the full blood count at that time, hemoglobin was 9.5, which is moderate normochromic normocytic anemia. Leukopenia with a WBC of 2.5 and neutrophil count of 0.2, neutropenia. And also thrombocytopenia of platelet of 35. So if you notice here, the monocyte count percentage was actually 52% with absolute monocyte of 1.3. Okay. So on smear, actually, what we see is actually these abnormal cells. Morphologically, it looks similar to monocytes. So that's why our automated analyzer counted the cell as monocytes because of bilobated nuclei and abundant, moderate to abundant cytoplasm. But actually, this is actually an abnormal promyelocyte. Okay, this cell exhibit bilobed nuclei with granular cytoplasm, and you can actually see occasional aurochs. Okay, there are also occasional faggot cells noted. Faggot cell is referring to the cells with bundles of auroch. Okay, but it is very occasional in the full blood picture. So we reported as pancytopenia with presence of abnormal promyelocytes to consider acute promyelocytic leukemia. So this is the bone marrow smear. So this fragment was hypercellular for age with cellular trails. So the cell trails were basically composed of these abnormal promyelocytes. There are hardly any megakaryocytes. Okay, there's no maturation in the granulocytic series observed, no mature neutrophil or metamyelocyte. You can see occasional nucleated RBC here. This is macrophages and also occasional lymphocytes. Okay, on further magnification, the cell trails show presence of more than 90% abnormal promyelocytes. Okay, these abnormal promyelocytes exhibit deeply bilobated nuclei with hypergranular and irregular cytoplasm. So the cytoplasm outline was irregular. Okay, then occasional aurochs noted. Other hematopoietic lineages are markedly suppressed. So we proceeded with peroxidase, and these cells were strongly positive for peroxidase. This is another clue that leading that this is confirmed to be acute promyelocytic leukemia. Okay, so impression from the marrow was hypercellular marrow with presence of numerous abnormal promyelocytes. Findings are consistent with acute promyelocytic leukemia. we proceeded with urgent molecular study for this case. Okay, so this is our screening panel. It has M1 to M8 panels. So all this panel actually consists primer to detect 28 common translocation in acute leukemia and CML. So you see there's an abnormal, there's band here. So the size of this fragment is actually between 300 to 400 base pair. Okay, and then when we have positive in N4, we proceed with further split panel for M4, which consists of M4 to 4D. Again, there is fragment present at in between 300 base pair and 400 base pair. And then we refer to our interpretation table. The only translocation that can be detected at M4D is translocation 1517, PML-RARA, okay, with 325 base pair, which is tally with this size of the fragments. So in this case, it's confirmed that this patient has acute promyelocytic leukemia. So this then further supported by immunophenotyping that was performed on the bone marrow sample. So this is our acute leukemia orientation tube. So there are actually 80% promyelocyte. If you see this red population at 45 dim and high site scatter. If you can recall our previous CPC for TALL or BALL, most of the blast located at the low site scatter because the blast is small with scanty cytoplasm and rounded nuclei. But in this case, because promyelocyte is very complex structure with granular and also lobated nuclei, so it is found in the higher site scatter region. So this abnormal promyelocyte also express strong MPO, negative for B and T markers, negative for T markers, which is cyto-CD3 and surface CD3. Okay, some of the population of this promyelocyte also express dim CD19 and also dim CD17 alpha. Because of the dim expression, we have concluded that this is just aberrant expression of 19 and 7 alpha in the promyelocyte. Some of the promyelocyte also express CD34, which usually APML 34 is negative, but it can also be found in APML with small population with 34 positive. We proceeded further with AML tube 1 and tube 2. So again, these abnormal promyelocyte are expressing typical markers for APML, which is CD117 positive, HLA-DR negative, CD13 hetero, CD16 negative, CD10 negative, and it usually will have homogeneous CD33 expression. Unfortunately, during this time, we ran out of our CD33, so we did not add CD33 in AML tube 1. However, CD13 was hetero. And then this is also typical markers of APML, hetero 64 and also dim to negative CD35. No monocytic markers was present in this abnormal promyelocyte. Therefore, again, we concluded that this is actually acute promyelocytic leukemia. Okay, so this is the T5 biopsy that we received together with the bone marrow. So this is the slide. You can see that we have a very good size, very good length of T5 biopsy. However, on further magnification, pardon me, I was trying to get all these T5 in one slide. So I have to capture each of it in one picture. So this is like jigsaw puzzle, but actually I managed to show the whole length of the T5 biopsy. So you can see that there is only one or two marrow spaces that has a very good tissue. However, the rest of the intertrabecular area has suffered major tissue losses. So this is usually because when we take the T5 tissue from the area that we aspirated before. So the bone marrow aspirate was taken from this region. So then that's why we have lost tissue loss here. However, I managed to get this area to be magnified on the next slide. Okay, so this is the T5 biopsy again. So when I magnify this area on the first, on the last cut of the T5, the marrow shows hypercellular area for each with disrupted marrow topography. There is no fat space available, no megakaryocyte seen. And then the normal hematopoietic cells were displaced with sheets of medium-sized blast or promyelocytes. Okay, so this cell is a bit round to irregular nuclear outline. And then you can actually see the bilobe nuclei with prominent nucleoli, and they also have a moderate to abundant amount of cytoplasm. Hardly any mature neutrophil seen, no megakaryocyte seen. You can actually see one neutrophil here and one eosinophil here. So there are the other hematopoietic cells will markedly suppress. So okay, so I'm sharing with you the normal granulocytic maturation pattern. So it usually starts from begin with myeloblast. Myeloblast with rounded nuclei, prominent nuclei, moderate, scanty to moderate amount of cytoplasm, and then it will further mature to promyelocyte. Promyelocyte will have rounded nuclei, prominent nuclei, and granules, primary granules in the cytoplasm. It will then further mature to myelocyte. In myelocyte, you will start to lose your primary granules and you will have secondary granules. The cytoplasm will start become pinkish. And then starting from metamyelocyte, you will have indentation in the nucleus. And then further, you will start to have segmented neutrophil as the most mature in the granulocytic series maturation. Okay. However, in APML, when there is translocation between chromosome 15 and 17 at Q24 and Q21, temerara, so it will cause arrested maturation in the promyelocyte maturation. There's no maturation further to myelocyte, metamyelocyte, band, or neutrophil. So this will also cause pathologic changes in the morphology of the promyelocyte, whereby it has aurochs, and then when it has bundles of aurochs, it will be called faggot cells, prominent nucleoli. And like in our case, most of it we have this bilobe cell with aurochs, prominent auroch. And then again, we know that this malignant promyelocyte is notoriously known to release this procoagulant, fibrinolytic, proteolytic substance and cancer cytokines that can cause DIC and other complications. Okay, then that's all. Maybe the cytogenetic study. Stop sharing.
Right. For patient number 3, Rex form sample was received on the 21st of September with the diagnosis of APML. In this patient, the OSA examine show an abnormal karyotype, which is 46XY translocation 15, 16, 17. As we see in the karyotype, the part of the chromosome 15 at band Q24 is translocated to chromosome 16. So from the part of the chromosome 16 at band P13 translocated to chromosome 17, and for the chromosome 17 or the band 17q21 is translocated to chromosome 15, resulting in the formation of the PML-RARA fusion gene 1517. So for 3-week translocation, so actually the crucial event is lie on this derivative 15. This is another karyotype showing the abnormality. That's all from cytogenetic.
Can I ask the tree translocation is interesting because usually we only see in 17. Is this something special or what do you?
The 1517 is the classical one. 3-way is considered variance. Sometimes we can see also lah.
Oh, tengoklah. It's 3-way translocation. Alamak.
Does this have any prognostic value?
Actually, actually the prognosis is still good because actually the active event is occur at the derivative 15, meaning that this patient will respond to the treatment.
Okay, thank you. Did you look for any article that has this kind of translocation?
Actually, the trivial transfer, a lot of article reported that maybe it's not involving the chromosome 16 with other chromosome also possible.
Okay.
Okay, thank you.
Okay. Now, seems like we are a bit running out of time. We will keep the number 4 case for our next meeting. Is that okay, Dr. Noazina?
Yes, actually we did not prepare yet for the 4th case.
Okay, okay. Then it's okay. Okay, thank you, everyone, for the concise sharing. We will see you again on our next meeting.
Do we want to
Mm-hmm.
decide the date now or later?
We try to decide now lah ya, Kogi. And then we
Yeah.
because it's going to be December soon. So 14th of December, Thursday.
14th of December, I got a meeting.
Okay, so how about 13th?
Yeah, 13, 14 CPG meeting.
Ah.
The following